In this video, we're going to focus on emesis. In particularly, we're going to focus on the diseases that cause emesis at day 0. That is the first day of life. Now, kids can spit up. That happens all the time. As long as it's not projectile and is formula colored, babies can overeat. And that's why you throw them over your shoulder and tap their back and have them burp. And they sometimes spit up a little bit. That's not pathological. What we're talking about is projectile vomiting because there is an obstruction that prevents food from going down the GI tract, so it ends up coming back out the in-hole. What we're talking about here is baby emesis. And that's where I want to start. Because if baby is throwing up, what you want to do is examine the emesis itself. And you want to ask, first, is it pathological? And second, is it bilious? Because as we just discussed, normal feeds, where you need to do nothing about it except tap the baby's back, happen when it is not projectile, is formula colored, and occurs after eating. You don't have to worry about that. But there are two types of emesis that you do care about. And that's going to be separated into bilious versus non. Now both of them are pathologic. Both of them are going to be projectile. It's just that biliary emesis is going to end up being green, and non-biliary emesis will not be green. And the idea is this. Here's your baby. The esophagus gives rise to the stomach to the pylorus, to the duodenum, and then the rest. If you've got biliary emesis, it means that your obstruction is distal to the biliary tree. It still can't go the way it's supposed to go, but at least it's touched some of the bile, the biliary tree, which is what makes it green. If, on the other hand, you had an obstruction that was higher, say at the level of the stomach, there'd be no opportunity for the bile to get back into the stomach to vomit it up. It helps you to know if the vomit is bilious, green, or not. Let's handle bilious vomiting first. When you have bilious vomiting, it means you've got some obstruction distal to the ligament of Treitz. And what you're going to do is use the X-ray, which is going to show you a double bubble. But it's in addition to the double bubble, it's going to help you as well as the uterine course. And that is how you're going to separate out these different diseases. Let's start with malrotation because it's the most unlike the others. What's supposed to happen normally is that the gut comes out of the abdomen, spins a little bit, and comes back in. That's part of embryogenesis. If that failure of rotation happens, you could be at a point where bowel is crossing each other, strangulating itself, causing an obstruction and potentially vascular compromise. So this happens in a normal pregnancy. So it'll be a normal uterine course. Mom's not doing anything wrong, no cocaine, no alcohol. She went to her usual visits and she didn't have any problems with polyhydramnios. She got her triple screen or a quad screen and there was no Down syndrome. And yet, when baby comes out, there's still biliary emesis. Well, malrotation happens quite late in the game and could actually be a volvulus here in front of you. The diagnosis is going to be made with the babygram. Remember, the X-ray is going to be on such a small human that effectively if you take a picture of the entire baby, you're going to see the double bubble. But because it happened so late, there was a chance for air to get into the bowel. And so you'll see a normal gas pattern beyond. Now, late in the course or in its high severity, you may not see any gas at all, but because it's step 2, they can't throw wildcards at you like that. Double bubble with a normal gas pattern beyond is malrotation. To confirm that, you could do an upper GI series. And what you're going for is there an obstruction? If you see a cutoff point or transition point, you know for sure malrotation and obstructed. Now, if you've watched the medicine videos already, you know how to conservatively manage somebody who's got intestinal obstruction. You give NG tube, you set an intermittent suction, and you decompress. Now, malrotation is generally going to be cured by surgery, especially if you end up getting a volvulus, where it's not just the bowel wrapped around itself, it's ischemia because the vascular supply has been compromised. The other 3 are very similar to each other, and 2 are actually almost identical. So let's talk about duodenal atresia and compare it to malrotation to see how different it is. Now, the duodenum starts off with this very, very narrow lumen. And what's supposed to happen is that it recannulates. That is to say, there's a nice big open lumen for things to move forward. If this process does not happen, that is, the pathogenesis is a failure to recannulize, what you're left with is effectively a complete small bowel obstruction. And this is how it ends up working. Blood flow to baby through the umbilical cord is great. Perfusion to baby's kidneys is fine. It's peeing. So it's making amniotic fluid. Baby is supposed to be eating and swallowing that amniotic fluid, but because it's got a complete atresia, it's got nowhere to go, so it comes back out. If you make the same amount, but absorb less, there'll be more of it. And so what you'll see is polyhydramnios. This is also associated with Down syndrome. And of course, baby's going to have biliary emesis. The diagnosis is made with the babygram, that is the X-ray, that shows a double bubble. Because duodenal atresia happens so early on in the development, there's been no opportunity to get any air into the bowel. So you're going to see a double bubble plus no gas beyond. The only treatment we have for this is surgery. Remove the atretic segments, reconnect everything, and the bowel should move. Now, annular pancreas looks an awful lot like this. This is the gut. Here is the pancreas growing on one side and on the other. What's supposed to happen is that one of these rotates or goes through apoptosis and disappears, and what you end up with is the biliary tree connected to a pancreas. But if it doesn't die and it hangs around, you can see how that pancreas would encircle the lumen and as it grew would just squeeze down on the duodenum. And so this is a failure of apoptosis of the pancreas, and so what ends up happening is effectively the same thing. And so all the same logic applies. The person is going to have polyhydramnios. They're going to have biliary emesis, and there's an association with Downs. Now this happens pretty early on, so when you get that babygram, the X-ray is going to show you a double bubble, but it's going to show you no gas beyond. And of course, you have to remove that to relieve the obstruction, so the treatment is surgery. And if you've been paying attention and riding along, annular pancreas and duodenal atresia are effectively the same disease. You don't know until you get into the belly and start fixing it what the actual problem is, because you have total obstruction and it looks exactly the same. The one that's not the same, though, is intestinal atresia. Watch the names because they sound alike. Where duodenal atresia is primarily a problem of genetics, that is, Down syndrome associated, intestinal atresia is mom doing it to her baby. Intestinal atresia is caused by vascular accidents in utero. Some sort of vasospasm has occurred that has cut off the blood supply to the developing gut, and those segments become atretic. Mom generally does some sort of vasoconstrictor, such as cocaine. It happens late in the disease course, so while there could be polyhydramnios, you don't necessarily have to see them. It depends when this happens during development. And there's no association with Downs. But because this vascular accident happens in multiple places along the intestine simultaneously, what you're going to see is not just a double bubble. The babygram, the X-ray, will show a double bubble and multiple air fluid levels, implying at each air fluid level there was another atretic segment. Now, because we know how to treat atresia, right? So what we're going to have to do is surgery to remove the atretic segments. What we're really worried about here is short gut syndrome. The more bowel you have to remove, the less surface area there is, and short gut syndrome is a malabsorption syndrome. You simply don't have enough intestines, and there's not a transit time and is not long enough to absorb everything that you need, and you end up having terrible diarrhea. But here's why this is different. You need to confront mom. Maybe she's got a medical disease that predisposes her to arterial thrombosis, or she's doing something to herself that's going to hurt her kid. And if you confront mom, you may be able to prevent this from happening on the next child. So biliary emesis, you're going based on the hydramnios, the triple or quadruple screen, and the X-ray pattern. But ultimately, the result is surgery to fix it. So you have to. The non-bilious emesis that is going to be on day 0 is a tracheoesophageal fistula. And if you remember from embryology, there's about 5 different types. And you could have any combination of atretic pouches or fistulas. Well, I want to give you an idea what that looks like so you have the mental image. Here's baby. The most common is type C, that's what I'm drawing, where the esophagus has a blind pouch. It continues to the stomach, but only through a fistula. Now, it doesn't have to have a fistula, it doesn't have to have an atretic segment, but the combination of blind pouch and some sort of connection to the trachea means that no food gets to the stomach, most of it ends up in the lungs, and as this blind pouch fills up, it's going to bubble over and cause more aspiration. So baby is going to present, day 1, non-biliary emesis, but more importantly, gurgling and bubbling. Baby is going to be breathing through gastric secretions. So you are going to see bubbles as baby just sits there breathing. Got to get this fixed. But to diagnose it, this is a board favorite, is the NG tube that coils on X-ray. You try to put an NG tube down, it goes into the blind pouch, you take a picture, it's all coiled up. And because this is compromising baby's nutrition from day 0, the first thing you want to do is get some parenteral nutrition to prepare baby for surgery to reconnect the blind pouch with the rest of the esophagus. Now, we didn't leave much space on the board for it, but the last one I want to talk about is pyloric stenosis. This is almost never an emesis on the first day of life. Usually it occurs at weeks 2 to 8. Because we're talking about baby emesis, it's worth talking about now. What happens is you get hypertrophy of the pylorus, and that leads effectively to a gastric outlet obstruction. The patient is generally going to be male, and at 2 to 8 weeks, someone who had normal feeds is all of a sudden going to go to projectile vomiting. And it is non-bilious. Because the level of the obstruction is at the gastric outlet, there's no chance for there to be any bile. You're going to see certain things on the test that are going to tell you, okay, this is a pyloric stenosis question. You're going to get one. And that is going to be things like the olive-shaped mass, or visible peristaltic waves. You see that, diagnosis is done. And often it's not going to be, what's the diagnosis? They're going to lay it on really thick. You're going to know for sure the diagnosis. Where they're going to get you is on what you do next. Because to make the diagnosis of pyloric stenosis, you're going to do an ultrasound. And the ultrasound is going to show you a donut sign, not to be confused with the donut sign of intussusception. And because we're talking about surgical issues, not surprisingly, the answer is surgery. You do a pyloromyotomy. But you notice I left some blank spaces there. I did that on purpose. Because where the test is going to get you is on making sure baby is safe. What you need is a Chem 20, a CMP. What you're going to see is a hypochloremic, hypokalemic metabolic alkalosis, low chloride, low potassium, elevated bicarb. The reason for that is because 1, you're losing volume and having a contraction alkalosis, and 2, you're sacrificing both chloride and potassium in order to try to reacidify the stomach that you're vomiting up. This is a common finding in emesis, hypochloremic, hypokalemic, metabolic alkalosis. If you find electrolyte abnormalities, you got to fix them. So before you get that ultrasound, before you prep this baby for a surgery, what you need to do is give them intravenous fluids and correct electrolytes. And that's where they're going to get you on the test, because you're going to see the donut sign, you're ready for the surgery, but no, you have to take the time to give them some fluids first. So what we talked about was biliary emesis, intestinal atresia, annular pancreas, duodenal atresia, and malrotation, based on the presence of polyhydramnios, what mom was doing, and the screening for Down syndrome. And then talked about tracheoesophageal fistula, remember the NG tube coils on the x-ray, and pyloric stenosis, where you want to correct electrolyte abnormalities first, and then do the surgery. And always remember that a little bit of spitting up is not a big deal, so long as it occurs after feeding, and it's formula colored. That is emesis.